Namaskar and hello, dear viewers. Welcome to today's session of Critical Lines podcast on Young India Intensivist. And as we know, we call some great experts and minds from our country for this particular podcast. And today we have a very special guest, Dr. Sumit Ray. And I'm sure all of you are familiar with him. Nonetheless, he is currently the medical director and head at Holy Family Hospital, New Delhi, and he has been deeply associated with education in India in critical care. He is the ex-vice chancellor of Indian College of Critical Care Medicine, ex-secretary, and also he has been the examiner for various exams that you have associated with critical care. And he was awarded the Chikitsa Ratna Award by IMA Delhi a few years back. And I think it'll be a great session and great learning for all of you at whatever stage you are. So, sir, the first question is, it has three parts. It deals with oxygen support, ventilation, etc. in a patient with respiratory distress. So this patient, young patient, is admitted with typical patient fever, cough, pneumonia, respiratory distress. The ICU team finds the PF is 275 and puts him in nasal prongs. So is it okay to continue with nasal prongs, or should we put him on mask or NIV or high flow? So how do you decide and what should be done here?
Well, I think a hypoxemic respiratory failure, depending on the level of tachypnea and distress that the person has, and the hypoxia, I heard you correctly, the PF ratio is to about 275. So even with that PF ratio, a nasal prong may give the adequate amount of oxygen. But the advantage of if one has access to an HFNC high flow nasal cannula, is that for two reasons. One is the flow demand that the patient has in this state where they are tachypnic. Actually, the HFNC is able to reach the flow demand, and a certain fixed amount of FiO2s, close to the fixed amount of FiO2 that we have targeted, is able to reach the patient. Which with the nasal prong, probably with the tachypnea, with the dilution that is happening, we probably will not be able to achieve the target. So I possibly will, depending on the the clinical condition of the patient, probably shift him to an HFNC. The other reason I would do that is the role of a high flow nasal cannula is the high flow itself. If you are able to convince the patient to breathe with their mouths kind of closed, mostly nasal breathing, easier said than done in a tachypnic patient, the end expiratory lung volume improves, and actually the work of breathing reduces, and maybe a slight PEEP is generated even without generation of PEEP. Certain studies have shown that just the high flow itself improves the FRC, or the end expiratory lung volume, that itself reduces the work of breathing and actually possibly reduces the possibility of intubating some of these hypoxemic respiratory failure. This seems like to be a patient without underlying comorbidities, underlying respiratory illnesses. So this is a setting for probably an HFNC.
Thank you, sir. So after a couple of hours, it seems that the saturation is falling and PF is 175 and respiratory distress is not improving. So what should be the strategy? Should we continue with this, or we have to consider something else here?
Possibly looking at the ROX index, but as you said, if the saturation is dipping and the tachypnea is worsening, the ROX index, which is to see if the patient needs intubation in a person who is on HFNC, would start decreasing, and thus possibly would require intubation. I would not use, with a PF ratio less than 200, I would non-invasive ventilator in this setting, pure hypoxemic respiratory failure, where it is not a cardiac reason, right? The reason being, it's not because of cardiogenic reasons that the patient has hypoxemia, where a positive end expiratory pressure will help in the preload and the afterload and improve oxygenation. In this case, it's a primarily respiratory reason, where giving NIV in a young, healthy adult with a severe respiratory distress could end up causing, what is called PCL now, patient self-inflicted lung injury. I don't like that term. Now it's called ILI now. Also, the term ILI is used. So probably not the best setting for a non-invasive. PF ratio less than 200. So already getting into the moderate level of ARDS, worsening pretty rapidly from 275 to 175 in 2 hours. I would probably not hesitate to intubate this patient. 30-year-old, reversibility is pretty high, salvageability is pretty high. So I would rather intubate this patient.
Right, sir. So, no, the patient, the team decides to wait 1 or 2 hours more, but there's further worsening, and he's intubated. ROS index is rapidly worsening, and he's managed with invasive ventilation. So, we have these targets on invasive ventilation, keep plateau pressure less than 30. Now they're saying 27, 28, or a mechanical power of less than 17, or a driving pressure of less than 15. So, out of these targets, what would you like to choose as your target for ventilation, sir?
So, host of things. I think not just one target. The driving pressure is a good target because titrating the PEEP, titrating the tidal volume based on the best possible driving pressure that you get. And evidence suggests that a couple of good studies have shown that even when you are looking at the mechanical power, which is, for ergotrauma, it has been found that the dynamic energy, the dynamic part uh, of the potential energy, which is the difference, the energy generated from from PEEP to plateau. When you move the lungs from PEEP to plateau, shows the strongest correlation, even within mechanical power. That is what shows the strongest correlation to outcome, which is exactly the same as what driving pressure gives you, right? So it is not just the whole mechanical power which is showing a correlation. Within that, there are three elements of drive of the mechanical power. One is the kinetic energy, which is the what overcomes the resistance of the airways. The and also the potential energy is of two stages: the static and the dynamic. The static being the energy required in keeping the lung inflated till PEEP. Between PEEP and plateau pressure, the energy required is the dynamic energy that is required, and that is equivalent in some ways, correlated, not equivalent, is correlated strongly with the driving pressure. So I personally titrate the vent settings, the PEEP, the tidal volume to the driving pressure more than anything else. Obviously, trying to maintain the blood gases as the least amount of minute ventilation required, because the higher the minute ventilation required in a damaged lung, the more chances of strain. So all these elements have to come together. Having said that, also looking at the CO2 level. Evidence now suggests that if the CO2 level tends to go beyond 60, PaCO2 level tends to go beyond 60, then the possibility of harm because of the right heart, the effect on the right heart, and leading to acute corpulmonal or right heart dysfunction can lead to worse outcomes. So the balance of all these elements is what one needs to look at. But giving a short answer to your question, more focus on driving pressure is where I would think that's where I would focus it.
Thank you, sir. So then, considering that the commonest etiology for such a thing would be pneumonia, would you consider a BAL to, kind of have a microbiological diagnosis?
Right. Not at this point of time if the patient is requiring high ventilatory support in terms of FiO2 and PEEP. Because if we go in for a BAL at this time, two things. One, you'll de-recruit, cause worsening possibility. Second is the evidence to suggest that a mini BAL or a deep suction and an ET secretion with a respiratory, PCR, respiratory PCR panels being sent is as good as a BAL doing it in the initial phases. I would not probably go in for a bronchoscopy at this point of time, not immediately. See if the lung compliance, etc., improves, the setting titration, etc., shows that I'm able to maintain the gases fairly well without very high PEEP. The oxygenation is good, and also the CO2. Probably what we don't focus on in the whole ventilatory process in ARDS is the CO2. We tend to focus on it in COPD or bronchial asthma, but in ARDS, a right heart dysfunction because of a high CO2 has a strong correlation to poor outcome. So focusing on the CO2, focusing on what is very interesting, I find, is the difference between the PaCO2 versus the EtCO2 gap. That also gives us a very strong indication of how the lungs are behaving, right? The dead space ventilation is given by that. And that is a very good indicator. And that is what we have to focus on, and based on those only where I see that there is an improving trend of that, then probably I may go on to a bronchoscopy, possibly not in the first 24 hours, send PCRs uh, and see what the possible organism is to treat it, and cover it with antivirals and antibacterials initially, and de-escalate as required.
Right, sir. Thank you, sir. So then, moving on to septic shock. Now we are talking about the most urgent and the most common things. So this was a little about ARDS. Now septic shock, and we have CRT, capillary refill time, which is very good
Right.
for resource limited ICUs, especially our country and so many other countries. Most of the ICUs are resource limited. So how do you actually use
Right.
at the bedside for septic shock?
So depends on what all modalities you have. If you do not have anything else but CRT and a non-invasive BP, obviously that's the only modality. But if you have an invasive arterial line, and you can do CRT on any patient, along with to have an ABG to give you acidosis, to give you lactates, etc. It's a combination of factors that I use. The simple one would be that you do. So the macrodynamic parameters that we target is the fluid responsiveness. In a sense, I personally use the mini fluid challenge the most. Mini fluid challenge, the pulse pressure variation or the systolic pressure variation also is helpful. Even just having an arterial line in, a systolic pressure variation is almost as good an indicator as a pulse pressure variation or a stroke volume variation to indicate fluid responsiveness, with the caveats that you have for dynamic measures of fluid responsiveness. One, having said that, I think probably if you have a mechanism of looking at mini fluid challenge where you give a 4 ml per kg predicted body weight fluid challenge over 5 to 10 minutes, or even smaller, 100 ml bolus in 120 seconds, and seeing how the cardiac output or the pulse pressure responds to that challenge, or a PLR easier said than done. To tell you honestly, very few of us do PLR. It's not as easy in the experimental setting, well and good, but in the clinical setting, not so easy to do. So I tend to use a mini fluid challenge to look at the macrodynamic circulation. Is the cardiac output responding? Once the macrocirculatory features are looked at, along with that, the microcirculatory features that I look at is the CRT. How is the CRT progressing? Is it improving with giving fluids or adding vasopressors? The other is, along with that, I don't use that alone. Maybe use a lactate, but also sometimes when in doubt, do a PVACO. To have a central line and an arterial line, I do a difference between the central venous CO2 versus the arterial CO2. But if you don't have all this, and you have only probably a peripheral access, an NIV, an NIBP, and you have access to CRT, which you can have for anybody, then give a fluid challenge. Look at the change in systolic pressure. Actually, we have a study now, which we got one of the best papers in the National Critical Care Conference, which we are in the process of publishing. Actually, a delta systolic pressure with a fluid challenge is also as good as a pulse pressure, delta pulse pressure, to tell you if the patient is macrodynamically responding to fluids. Along with that, do a CRT to see how the CRT clearance is happening. As you know, the Andromeda shock trial found that if you target lactate clearance vis-a-vis CRT improvement, when you target lactate clearance, you tend to prolong the resuscitation process and tend to give more fluids without more benefit in terms of mortality outcome. So I don't know if that answers your question. I gave a long answer to a short question, probably.
No, that's fine, sir. So the only thing is CRT should be used if you are not having all the advanced tools. It's pretty useful and it's pretty simple. But you cannot just use
Yes.
CRT. You have to assess at some point in time some dynamic parameter also.
Dynamic parameters, and you see separate the macrodynamic with the microcirculatory, right? CRT gives us a more perfusion related, but you have to look at the macrodynamics also. CRT will not tell you the limits, right? You have to look at the patient may be fluid responsive, but may not be tolerant, right? The patient may leak the fluid that you are giving, even if they are in the steep part of the Starling curve and they respond, the cardiac output increases, but it may leak out when there is damage to the endothelial glycocalyx. That's why now the surviving sepsis guidelines says, relatively less is more. That 30 ml per kg in 3 hours is a suggestion, not a recommendation.
Thank you, sir. So moving on to dengue. So dengue, is the number one virus killer in the world and afflicts almost all part of the world except Europe and North America. So, the use of VV ECMO in the setting of ARDS in dengue. Most of the patients are thrombocytopenic coagulopathic, which is a relative contraindication, but people have used for ARDS, dengue ARDS, VV ECMO, and there have been successful reports. So what do you think, sir, about this particular modality for dengue? ARDS.
Before I go to VV ECMO, couple of things with dengue. I think if anything scares me in the Indian ICU, it's a severe dengue. On one hand, they are fluid depleted intravascularly and they are leaking heavily. All of us know that, right? And it's exactly the same thing that I was saying, that they are fluid responsive but fluid intolerant in many senses. So in that setting, we are left with very few options. Before we go to VV ECMO, suppose dengue with ARDS. What is the reason for the ARDS in dengue? It is more not the, it's the more the leakiness of the endothelial glycocalyx, which is causing the extravascular lung water and the PVPI to increase, probably the extravascular lung water above the PVPI, and that is causing the ARDS. In that setting, how do we balance the fluids? So two things. One is probably this is a setting where we have to titrate our crystalloids a little more carefully, not like bacterial sepsis, go for the crystalloids of 30 ml before we move on to colloids. Possible use of earlier use of albumin, maybe. The other thing which is interesting is, and this comes from studies from the war zone, and it is very interesting, is the in hemorrhagic shock, which also becomes an inflammatory shock and damage to the endothelial glycocalyx happens. There is a loss of, the S1P, the sphingomyelin 1 phosphate, and that is what preserves and regenerates the endothelial glycocalyx. What was found, and I don't know if we can exactly extrapolate that, what was found in these large trials which were happened in Afghanistan and Iraq, is that when they transfused patients without even coagulopathy with hemorrhagic shock, during transport to the hospital from the site of injury, blast injuries, etc., if they transfused fresh frozen plasma, which is known to regenerate and S1P, those patients actually required less transfusion later, blood transfusions, PRBC transfusions, and the trend was for better outcomes. So possibly even in dengue, without too much of a coagulopathy, we should be looking at, with and without too much coagulopathy, we should be looking at possible transfusion. I'm extrapolating. It requires studies, requires research, and we should plan that coming from a country which we get a lot of dengue. That should we probably transfuse plasma? Should we transfuse colloids earlier in dengue compared to crystalloids so that we reduce the leakiness to regenerate the endothelial glycocalyx? That's the first part. Second is, should we do VV ECMO? I think, yes, I don't think there's a hard and fast rule. Difficult, dangerous sometimes, but backs against the wall, maybe. But I think we should, look at all these options that I spoke about before we go for that. And also what we have found in dengue is those with a significantly severe leaky endothelium post day 5 of the fever, there is a very strong element of HLH in many of them. Probably doses of steroids could work post the viremia phase, could be useful. So all these elements should be looked at before we jump into a VV ECMO. I would be very worried to go into a VV ECMO with a severe coagulopathy. It's not that we have not done, we have done it in a couple of patients. Didn't help much, to tell you honestly. Both the patient passed away. But young patients, backs against the wall, we had tried everything in that setting, but we are a little more aware. We do more plasma transfusions, albumin transfusions, and steroids a little earlier before we try that. And I think our outcomes with, and this is anecdotal, with dengue, severe dengue shock is improving actually in our setup and some other setups that I discussed. It's not just us. The same lines of thinking is going on.
Thank you, sir. So then moving on to again septic shock, we're coming back about fluid administration. So there are patients with congestive heart failure with low EF who are historically in congestive heart failure with pedal edema, etc., low EF documented, and they come in with septic shock. So how is fluid administration going to be different in these patients for resuscitation of septic shock and thereafter?
So dengue being different, septic, bacterial septic shock. I'm pretty clear now, more and more certain that it is I mean, all of us, I guess, are, that it is a vasodilatory distributive shock with a damaged endothelial glycocalyx. It's not a hypovolemic shock. I do not believe that a septic shock is a hypovolemic shock. So we are trying to increase the stressed volume to increase the cardiac output, right? And in a cardiogenic, in a patient with poor contractility, the possibility of a patient being preload responsive with fluid is unlikely. The patient is vasodilated with a poor contractility, low afterload, with a very less fluid tolerance. I would add vasopressors early in that subset, in these subset of patients, and give very little fluid and use, as I said, mini fluid challenges, PLR if possible, but I'm not very sure. But mini fluid challenges and see the response to those challenges in terms of cardiac output monitoring or pulse pressure, at least. If you have to have an arterial line in cardiac output by either a continuous cardiac output monitor or a VTI by a point of care echocardiography, and look at the responsiveness with the fluid challenges. That is what I would go, very mini fluid challenges, but early vasopressors. Now that is part of the evidence. The Caesar trial told us that probably putting in vasopressors early is a better option.
Yeah, thank you, sir. So use of early vasopressors, less fluids, and give it slowly, and more
Yes.
careful dynamic testing. All right.
Right.
Thank you, sir. Then the last question, sir, is about this study published in Intensive Care Medicine Journal in the September issue. It was about dosing of antibiotics, meropenem and piperacillin tazobactam in patients with AKI and CRT. It was a major study, a lot of sampling, and done by renowned experts like Jason Roberts and Mahalis Osterman, ma'am. So they gave nomograms after this massive PK/PD study. So do you think, sir, in the complex world of antibiotics and CRT and AKI, we can actually have nomograms justifying antibiotic dosing?
So the first thing I would say is it's an exceptionally well attempted study. I know it's a very difficult study to do. I mean, just reading through the trial gave me, kind of, I had to reread it a few times to know what was how did they do the study. Exceptional in that concept. It is a difficult one to do. It is one of the best we have had in that setting. It's work in progress, but at least a couple of things, very interesting things comes out of that study, the SMART trial, as you mentioned, that actually even on CRRT and SLED, 8-hour, 12-hour SLED, in moderate intensity CRRTs and moderate intensity SLEDs, actually giving the full dose that is recommended, that when the patient is on CRRT, giving the full dose of meropenem and the full dose of piperacillin tazobactam is recommended, kind of recommended. I think what the studies found out that if you give the full dose in that setting, you tend to reach slightly higher more towards toxic levels and beyond the target MIC levels that you want to achieve. And so the target levels you want to achieve, that was an eye opener. So for me, and actually, if I give a ballpark figure, what came through is that it's about 2/3 the dose for both these things, about, right? If I just use a simple ballpark, but it's a must-read study. It's a very well done study, and it will require more studies to prove it. But it's a very complex one to do, very difficult one to do. I must congratulate the authors for at least attempting to do such a complex study. Obviously, recruitment was difficult. That is the reason why the recruitment was difficult, and they had to extrapolate some amount of data from propensity matched cohorts, etc. So it is, but I think that is the potential way to go. Difficult one. It will require major statistical modeling also, which is kind of beyond me. It requires really complex statistical modeling too.
Okay, sir. Great. So I think probably we can use it for the time being as a indicator.
Yes, I think so.
Yeah, it's better than
I think so.
doing right now. So okay.
Right.
Thank you, Dr. Sumit Ray, sir. Thank you very much for your time and for your valuable contribution to teaching intensivists in India and across the globe. We shall put it up on our channel soon. Thank you, dear viewers, for joining in such large numbers. Thank you very much. Good night. And
thank you, Dr. Tapesh, for having me, and thank you for continuing to do this human work, in doing recording so many people's lectures, and the best across the world I've seen. You get the best speakers from across the world, from Canada to US to Europe. It's incredible what you're doing. Thank you so much. Thank you.
thank you, sir. Just a small contribution to education in our world. And happy Diwali, sir, and happy Diwali, dear viewers.
Happy Diwali to you too. Thank you.